Hi, Rob Orman here. If we are meeting for the first time, I'm a physician coach and host of the Stimulus podcast. And I want to pose a question to you, especially if you work in healthcare, although you don't have to, but especially. Which conversations with patients do you find the most challenging? What pops into your mind when I ask that question? It might be delivering unfavorable news, navigating incivility, either from consultants, from other clinicians, or from patients or families, talking with folks about the perennially broken healthcare system, or maybe, just maybe, it is saying no to patient requests. All of those things that I mentioned are challenging in their own ways, but saying no to patient requests, or what can sometimes feel like demands, that's got a unique flavor. Why don't we like telling people no? Well, if you are in healthcare, chances are you are a natural pleaser. You don't want to anger the patient. You don't want to anger anybody. You don't want to also have these things impact satisfaction scores. And it is exhausting getting pushback all day and saying yes just to avoid a hassle, just to avoid an extended conversation. It's so seductive. Saying no can sap your energy. A no takes a lot longer than a yes. And why do I have to explain myself? Who is the doctor here? For situations like this that can be taxing, where it's just so much easier to say yes, it can help to have a script. Why is that? Why a script? Well, script saves energy and it gets the conversation right every time. If you are feeling that you're at the end of your shift and your energy stores are low, it's going to be hard to create this conversation out of nowhere. If you are having the same conversation multiple times a day, or even a few times a week, that conversation or that snippet is ripe for a framework. And in the emergency department, it's often I'd say a discordance of understanding that leads to these situations, such as, let's talk about the situation, such as somebody who wants to get antibiotics for what is clearly a viral upper respiratory infection. There are other situations, such as somebody wants an MRI for musculoskeletal back pain where there's no red flags, or somebody comes in with asymptomatic elevated blood pressure. They're going to need to be put on some meds, but they were sent in because someone told them their head was going to explode because their blood pressure was so high. All of these conversations can sap you. In fact, there is a link in the description to this that goes through scripting for all of that stuff. But we're going to focus on the situation of patients asking for antibiotics for an upper respiratory infection. And these are, uncomplicated patients. And let's, give a fair shake here. Patients want to feel better and often have the belief that the path to feeling better is an antibiotic prescription. It's not like they want to just take antibiotics for nothing. They want to feel better. I think that'll do it for them. It is hard to blame them. This is the prevailing wisdom of much of the lay public. This is the prevailing wisdom of many of my relatives. And the conversation might go something like this. Hey, I've had a week of coughing, got a runny nose, sinus congestion. My doctor always writes me a Z-Pack. Can I just get a Z-Pack? Cough, and presented with a tissue with a big green slimy loogie. Check out my sputum. It was yellow yesterday. It's green today. Clearly I need antibiotics. Well, what's the common refrain from the clinician? Well, you have a cold. Antibiotics are not going to make it better. In fact, all they'll do is harm. And here you go. You laying out the harms, the science, the diarrhea, the toxic megacolon. You print out the most recent choosing wisely recommendations, and you deliver your logic. Now, some patients will, in fact, respond to a logical answer with logic as well. And when that happens, it's like drinking a glass of cold water on a hot summer day. But that is not the norm. The norm is to have pushback or even irritation. diarrhea, and all of those other horrible consequences of unnecessary antibiotics, they rarely register. While you are explaining your reasoning, while you're explaining your hard-earned knowledge, you think of all the CME hours you put into that. The patient's thought bubble probably looks something like this. Will they just give me my Z-Pak or not? Just say yes and let's be done with this. I want to go home. Now you think you're giving logic, but what they're hearing is no. 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 You cannot have what you want. Being told no and not getting what you want elicits an emotional response. They are experiencing emotion. Logic does not work well at solving emotional challenges. In fact, you know what? Logic not solving emotional challenges? Free bit of relationship advice for you. That's what I'm saying. So I'm going to talk about a few frameworks to address the situation. And in each, there is a basic assumption that you listen and that you respect the patient and their interests. Don't dismiss or invalidate. Think of it this way. If you hadn't done all of your medical training, you would probably have the same ask that they do. In fact, more than half of my physician friends take Z-Paks for colds. So, one cannot be sanctimonious about this. So you could say, this isn't really a framework, but you could just say, no, sorry, not going to happen. Not sure what else to say. Not going to prescribe them. So there you go. There's a bonus framework, just saying no. But let's talk about a few different structured approaches. Before saying no, make sure that you're not digging in your heels just out of reflex. That you are thinking about, okay, do they or do they not actually need these antibiotics? All right. I think that the answer is no, to the best of my medical knowledge. So this first structured framework was adapted from William Urey's work. He is co-founder of the Harvard Negotiation Project. And the framework goes like this. Respond in this order. Yes, no, yes. Let's break that down. Yes, the first yes. That's an internal yes. What really matters to you in this situation? You're not actually saying no. Well, you are. But what you're really saying is yes to something. In this case, it would be saying yes to avoiding harm and satisfying yourself that you're doing the right thing. Maybe that yes is, I'm saying yes to embracing the Hippocratic Oath and practicing medicine in accordance with those values. This sets the foundation of your purpose. Your yes is your yes, only you know it. There can also be an external yes, which we'll get to in a minute. But we've established that yes. What am I saying yes to? So that then what I articulate is no. And there's a critical element to this no. You are saying no to the issue, not the person. Now, this is a mindset shift from judgment. Oh my God, you really think you need antibiotics for this? I mean, you're clearly wrong. Judgment to discernment. Is much easier to say no to a question or an issue rather than a person. And it also shifts the mindset of the clinician away from judgment. And to that end, just digging a little bit deeper into that, it can be helpful avoiding you statements in favor of the statements. For example, here's a you statement. Well, you are incorrect in thinking that an antibiotic will fix you. Versus the idea that antibiotics effectively treat this kind of infection. It's common, and to the best of our knowledge, it's just not the case. So we've got our first yes, what matters to you, and then the no to the idea, not the person, and then finish with yes. This yes is the viable alternative. In this case, it's likely symptomatic relief or even reassurance. And a yes, no, yes might sound something like this. There's the ask, and you've got your internal yes. And okay, I want to do the right thing here. I don't want to harm this patient with unnecessary antibiotics. That might even be articulated. Hey, good news. Doesn't look like you have a bacterial infection or anything serious right now. Then the no. So you've told me that you've gotten better when you've taken a Z-Pak in the past. So there's validation wrapped in that. This is a common experience for many patients. Social proof, feeling better after starting antibiotics when they have a cold. In my experience, here's what I see happen with that. Those who do and don't take the antibiotics end up having the same duration of illness. And those who get the antibiotics get a whole lot more diarrhea. And there can be a final yes on top of that. Hey, it's no fun having a cold. I know I hate it. Compassion. And what I've found works well for this situation is this plan. And you might hear that, think, oh, amazing. I got the framework. I'm going to do it. Great. No, not so fast. Pushback is most likely coming next. Pushback that, come on, I hear all that. Just give me the antibiotic. Stay firm with your boundaries, but guide the patient to acceptance of the situation with kindness and compassion. Let's get into framework 2, which is unearthing your patient's special knowledge. And this approach comes from the field of hostage negotiation. It's a mindset shift from I have special knowledge to tell the patient that viruses don't need antibiotics to they have special knowledge that I need to understand. And the special knowledge in this case is what brought them to see you. It's what's behind why they want antibiotics. And how do you know that you have gotten to their special knowledge? It's when the patient says something like, that's exactly right. And you try to get to this before the physical exam. And special knowledge script might go something like this. So you've got chills, congestion, cough. What's on your mind? The patient. I can't be sick. I think I need an antibiotic. All right. Well, tell me more. The patient. My husband has Parkinson's disease. We are going to Tanzania in 2 weeks, but I cannot be sick for this trip. I'm going to be with a ton of people, many of whom are older, and I cannot be contagious. I need to be better. So you're thinking that if you get an antibiotic now, it'll make sure you're not contagious for the trip. The patient. That's exactly right. Then all right, let's do your exam. The patient feels heard and can address their actual fear, their anxiety, their reason for coming. In this case, you can say, well, you know what? You won't be contagious in 2 weeks. You might still be coughing, but an antibiotic won't change that. And you could get something like diarrhea from it, and that would throw everything out of whack for your trip. If you're hearing all of this thinking, yes, well, in the description below, there's a link to our free resource, Scripting Your Least Favorite Conversations, where we've got approaches to what you just heard, how to address patients who are concerned about asymptomatic hypertension, an approach to non-red flag back pain, and a patient requests an MRI, all that sweetness. There is a link below, free from me to you. Take care, my friends, and keep on rocking.